Good evening and welcome to On Call with the Prairie Doc. The Patient Protection and Affordable Care Act, widely known as Obamacare, in conjunction with the Health Care and Educational Reconciliation Act, has been in force since 2010. Right-wing conservatives in Congress have failed in many attempts to repeal it. Several governors have worked to block its implementation, and it's presently under the scrutiny of the Supreme Court. According to the Department of Health and Human Services, 16.4 million previously uninsured Americans have utilized the exchange to find health care insurance. So, how far have we come, and where do we think we might go as we move forwards to the future? To look into that murky crystal ball tonight, I am joined by Tom Dean of Horizon Health Incorporated in Wessington Springs. Thank you, Tom. Dr. Dean. And Dr. Don Hatton of the Reed Medical Group in Lawrence, Kansas, and he's joining us tonight via Skype. Thank you, Don, for joining us.
Thank you for having me.
So here we are now telling us, let's just find a little bit about each of you. Tom, you are a Wessington Springs boy. Did you grow up there?
I did. Actually, my great-grandfather homesteaded a few miles from where I grew up. So
wow,
we have deep roots.
And your dad was a physician there?
No, he was a farmer.
Was a farmer?
I grew up on a farm.
Oh, really?
My uncle was a physician.
Your uncle was the physician, that's it. In fact, I knew that at one time.
Okay.
And so where did you go from there?
Well, I graduated from high school in Wessington Springs. I went to college at Carleton College in Minnesota, and then I traveled around a bit. I went to medical school in Rochester, New York, and did a year in England, and then
What was that?
Well, it was a year-out fellowship that the university sponsored, so I studied the structure of British general practice.
Oh, really?
A fascinating experience.
Wow.
Fascinating experience.
Wow.
And then I went to University of Washington in Seattle for residency in family medicine, which was really one of the first family medicine residencies around. It was a long time ago.
In
Went there in 1972.
Okay, so one of the first family physician programs.
There was about a dozen residencies at that point.
Right.
Yeah.
And then you came back to Wessington Springs.
By way of Kentucky. We spent 3 years in southeastern Kentucky in the National Service Corps before I came back and my wife did midwifery training in a very interesting program in the mountains of southeastern Kentucky.
That's right, I remember hearing that story. And then you came back, and then somewhere along the line you were on the MedPAC.
That I just completed, yes.
Yeah, tell us about what the MedPAC is.
MedPAC, you hear PAC, you think Political Action Committee. It's not.
Yeah.
MedPAC stands for Medicare Payment Advisory Commission, which is a branch of Congress that advises Congress on Medicare policy. And so it's a group of 15 people of widely diverse backgrounds, about 5 physicians, economists, actuaries, administrators, lawyers, a very diverse group that reviews all the functions of the Medicare program and then produces reports regularly to advise Congress on Medicare policy.
Wow, I mean, you know, that's a heavy-hitting group.
It was a great experience. It was a burden. We met actually 8 times a year, so I ended up going to D.C. almost every month for a while.
Wow.
And I served there for 6 years and just completed a year ago.
So has that been a relief?
I have mixed feelings. I don't miss the airplanes.
No.
But I do miss the discussions. It was a fascinating group. Fascinating group.
Wow. But you were like the one practicing physician in the group, or was there another?
I was the one rural physician. There were a couple other practicing physicians.
Wow.
Yeah.
All right. Well, welcome.
Thank you.
Don, tell us a little bit about you. Where are you from originally?
Well, I am from Kansas. My family also grew up in Kansas, in western Kansas. My father and mother both went into medicine, my mother into nursing, my father into psychiatry. And from there, I learned that I wanted to be a physician. I did all my training in Kansas, with one exception of spending 3 years in the Navy. And I was a family physician on board ship and in Dependence outpatient clinics. So I, much like Tom, thought I wished to do primary care, though I chose to go to internal medicine so that I was to a certain extent, more hospital-based for a while. I've been here in Lawrence, Kansas now, the same practice for 40 years. During that time, I've done a fair amount of medical politics, both in the Kansas Medical Society and also in my internal medicine organization. And I love the internal medicine organization, largely because I met you, Tom. Rick, I'm sorry, I met you, and I met Tom too, but Rick and I served on some of the same boards and some of the same committees, so that's been a real treasure.
Right. So, Don, that's really interesting, the internal medicine organization, the ACP. You raised to the leadership, you were on that whole group. That was the reason, and you were my class leader, so you were the introduction for me when I was the governor of the ACP for South Dakota in this national organization a few years back, and we've sailed together.
Yes.
That's been a joy. And so, but you've also worked on an insurance company on a board, right?
Yes, I was chairman of the liability insurance company that the Medical Society here in Kansas developed 25 years ago. And it's been a going interest and really been a big, very strong supporter of Kansas medicine.
Okay, and that gives you a perspective, I think, that's also interesting on this show of discussion on healthcare policy. And we're going to talk about the ACA, which is the acronym for the Obamacare that everybody talks about. So I think that's an interesting way of looking at it. We have a question from the street that I thought might be a good way to introduce this discussion.
Obamacare, what is it? What's in it? What's it all about?
So that's the question. What is Obamacare or the ACA? Tom, would you take a shot at that? One quick explanation?
Well, there's not a quick explanation because it's a very big piece of legislation. And the thing that people are most familiar with is the requirement that everybody either obtain insurance through their employer or purchase insurance individually. That is an important part of the law, but it is only one small part of the law.
All right, and we'll get right into that question further. But before we get too deep into it, let's take a moment and look at another explanation of the ACA.
Health insurance and the costs of not having health insurance have been debated in the United States for over 100 years. In the early 20th century, as Europe and the United Kingdom were enacting socialized health care, most Americans rejected the idea of the government providing health insurance. It wasn't until the 1965 Social Security Act that the United States offered its first government-administered healthcare system called Medicare and Medicaid. Since then, several healthcare reforms have been proposed but never gained enough public support. In 1989, the Heritage Foundation proposed an individual mandate for health insurance and as a market-based method to healthcare. Since the 1990s, healthcare reform has been an issue every president has tried to tackle. The Obama administration is the first to sign into law an act that requires every individual to have health insurance. On March 23, 2010, the president signed the Patient Protection and Affordable Care Act into law. In the first year, the ACA required insurance companies to cover children with pre-existing conditions and young adult children up to age 26. Insurance companies were also to remove lifetime limits on essential health benefits such as emergency services, maternity and newborn care, prescription drugs, laboratory services, preventive and wellness services, and pediatric services. In 2011, the ACA required prescription discounts and Medicare preventive services for seniors. The law also required a new 80-20 rule, which says only 20% of premiums collected by insurance companies can be spent on administrative and marketing costs. 22 preventive care services for women were required in 2012. These services include breast cancer screenings, well-woman visits, and domestic and interpersonal violence screening and counseling. Insurance companies were also required to provide customers with a new, easy-to-understand summary of benefits and coverage and a uniform glossary. Health insurance open enrollment and the marketplace at healthcare.gov opened in October 2013. 2014 brings marketplace coverage, coverage for pre-existing conditions, and federal assistance for monthly premiums and out-of-pocket costs. Medicaid expands in some states, and annual limits on essential benefits ends. Insurance companies may still levy yearly and lifetime limits of up to $2 million on non-essential benefits. Americans have until March 31, 2014 to enroll in a health care plan, apply for assistance with premiums and out-of-pocket expenses, or apply for a health insurance exemption. For more information, visit healthcare.gov or call 1-800-318-2596.
So that 16.4 million that now have health insurance that didn't have it before, what percentage of it, of the people who didn't have health insurance did that include? I mean, it was 54 or something like that, isn't it?
I think it was somewhere in the range of 45 million.
45 million.
And so the 16 million, the percentages that they have been released just recently as the open enrollment period just closed, was that the proportion of uninsured dropped from about 20% of the country down to 13%. So it's a substantial improvement, but we still have a significant number of people that are uninsured, but it's a big improvement.
13%. So what would be the reason, Don, what would be the reason that we don't have more than 13%? I mean, Obamacare was supposed to provide, I mean, not Obamacare, the ACA, let's call it that, was supposed to bring that percentage down to include everyone, at least those who are legal
residents, yeah, legal residents.
So why are we down still having 13% uncovered?
Well, Rick, I think you don't need to apologize calling it Obamacare, because in one of the interviews and one of the debates, one of the people who was debating President Obama called the Affordable Health Care Act Obamacare, and then he turned to Obama and said, "I'm sorry I said that." Obama turned to him and said, "I kind of like it." So, Obamacare is fine by me. If you look at across the United States, there are differences because of the fact that some states chose to have their own exchange, others chose not to, some chose to expand Medicaid, and others chose not to. If you go back and look at the history of the healthcare reform recently, the most recent thing prior to Obamacare was the Massachusetts experiment that some people called Romneycare. Massachusetts is the state in the country that has the highest amount of people who are covered, and their uninsured rate is about 4.5%. If you look at another part of the country and look at Texas, Texas is the state that has the highest level of uninsured at about 24.5%. So it depends on what the state did, both for the exchanges and for expanding Medicaid, as to how the uninsured rates are going in those particular areas.
All right, thanks.
Add just a little bit. One of the really interesting things that was the outcome of the Massachusetts move was that even in a state where they had low levels of people who were not covered, it's a relatively high income state, a state with certainly many world-class institutions, but even with all those things to begin with, the mortality rates dropped 6% in Massachusetts after this program was introduced. No, after Romneycare was introduced.
Right.
And whereas states around the adjoining states, it stayed stable. And they showed that the drop in mortality was most dramatic in those low-income areas, that even in a wealthy state, people were not getting adequate care.
So it
improved the outcomes, even in a state that had good outcomes to begin with.
Improved quality. I mean, they were similar to the other states around them, but in that state, when only 4.5% are not covered, the outcomes got resolved. What about the cost?
Outcomes got better.
Yeah, outcomes got better. Yeah. What about the cost in Massachusetts?
Well, Massachusetts is an expensive state. It was before this, and it still is. I don't know exactly what has happened with their costs. They still have significant cost problems, from my understanding.
So one of the things that you said, Don, about the difference between states has to do with expanding Medicaid. Some states did, some states didn't. I mean, originally, the ACA said everyone has to cover it. The Supreme Court said, no, it's a state's rights choice. And so half the states didn't, and South Dakota is one of those states. Texas is one of those states. Kansas is one of those states. Did it change the outcome for access?
The fact that the Supreme Court did make that decision was, I think, a problem for expanding Medicaid, because it did make people try and decide whether or not they could afford to expand Medicaid. And I think in Kansas, one of the things was that even though for the first 3 years, the federal government is going to cover all the costs of the expanded Medicaid, after the 3 years, it's going to be turned to 10% goes back to the state, and the state then has to cover that. Kansas at the present time has some budgetary issues, and I think the whole idea of having yet another amount of money pushed upon the state to cover more Medicaid patients made them not want to get involved with it. I don't say that that is the right decision, but that's what was decided. Presently in Kansas, we're re-looking at whether or not we might be able to expand Medicaid in a way which we could afford. And that bill presently is being discussed in the State House right now.
Tom, what's your take on South Dakota and Medicaid?
Well, I think it was some of the same reasoning, which I didn't always agree with, but the concern that the governor expressed was that you couldn't rely on the federal government down the road to continue to support these commitments. In fact, if you look at the conventional Medicaid program, going back 40 years, the federal government has never reneged on their portion of it. So it's hard to tell, but there is this innate fear and innate concern about the federal government living up to their responsibilities, and I think that was the biggest drawback or biggest fear.
But we would have had more access. I mean,
absolutely.
It's the working poor.
Absolutely, yeah.
And we're not getting that at this point.
And it has created some significant problems for healthcare facilities, especially hospitals, in order to back up. The American Hospital Association enthusiastically supported the
passage of
ACA because they felt that if everyone was covered, they wouldn't have any more uncompensated care or patients without resources. And so they agreed to accept lower reimbursement from Medicare because of this assumption. Now, what happened in the states that didn't expand Medicaid is the hospitals get the worst of both worlds. They get the Medicare cuts that did stay in place, and yet the states are not expanding Medicaid, so they still have a significant number of uncompensated patients without resources who aren't able to pay their bills. So they're getting lower reambrsment from Medicare and still have a number of uncompensated care. So it's a tough time for hospitals right now.
Hospitals are taking it in the shorts right now.
It's a big concern.
Let's have the question number 5 played at this time from Mr. Warman, please.
Good.
Here we go. So.
Well, I'm particularly disappointed in South Dakota's leadership in not making the Medicaid available to more of the customers who would benefit from access to health care. And the money spent would really fall into the medical providers' hands as those people got the care they needed. It's the best economic development that I can imagine for the state, far better than some of the things that have been done in the last 10 years.
Speak to that a little, Tom. I mean, how much money would South Dakota have received the first 2 years?
The projections were that it'd be around $200 million a year that would have come into the state had they expanded Medicaid. And I think that there's some real hidden costs here that oftentimes people don't realize. When people without resources arrive at a hospital, arrive at an emergency room, they get taken care of. But those costs have to be absorbed by the provider, and they in turn get passed on to all the other sources of revenue that the hospital has, primarily insured patients. So even if you have insurance, you are paying a significant amount of that insurance is going to cover the cost of these patients without resources that end up in the emergency room or in the hospital.
Right. So that's and there is $200 million, and then $200 million more that might have come into our state.
Might have come into state that we're not going to receive.
Rick, the other cost that I think needs to be looked at is the cost of the loss of the opportunity to take care of a patient at a time in their illness when the illness
Absolutely.
might have been cured, rather than at a late stage. And we do know that people who don't have insurance present to emergency rooms and to physicians at times when they are more ill than if they would have had insurance where they would have come forth. So I think that the human cost is very great.
Well,
So that, just to expand on that, that's a very important point, and people that are in that situation end up having worse outcomes and higher costs.
well, if you can prevent a hospitalization,
Absolutely.
that's a huge savings. They know that if an insurance company pays a lot of the diabetic medicine, and so that people don't skip the medicine because it's so expensive, but they get it pretty cost effectively, then they don't come in. One hospitalization counts for years and years and years of medicine.
There's a fascinating story that was reported from New York earlier this year, where a safety net hospital that dealt with the poor, which was working on a fixed budget, took their homeless population, or a number of their homeless population that were frequently admitted and frequently in their emergency room. They paid for apartments for these homeless folks, and they saved money.
By giving them apartments.
They gave them a place to live, and they actually cost the hospital less than if they'd had these repeated emergency room visits and admissions that weren't being paid for.
Right. Before I interrupted you, we were talking about what the ACA is. And so, I mean, I think one of the most important things that we have to understand is it is that individual mandate. It requires everybody to have insurance. And it requires insurance companies to insure everybody.
Right.
And if you don't have the individual mandate and insurance companies are required to insure everybody, then many people what would happen?
They would wait until they needed an operation or they needed some expensive medicine or something, then they'd go out and buy the insurance policy. And what would happen is the premiums that would be required to support that situation would go up, and it goes into what insurance experts call a death spiral. It gets higher and higher. The more healthy people drop out, the risk of the pool that you have goes higher and higher, and it becomes unstable and impossible to continue.
So that's the reason we have to have
That's why we have to have everybody in the pool, yeah.
Don, any thoughts on that?
Yes, Gail Lewinsky, who was head of HHS about 10, 12 years ago, wrote an article about why the ACA is not liked. And of course, the individual mandate has been one of those issues. There are other issues, like, for instance, somebody who has a rather basic insurance policy. When President Obama said everybody will be able to keep their own insurance if they like it, that was not absolutely true, because the ACA made people have to buy a minimum policy. So some individuals like their minimum policy of the lack of some coverage. And for instance, obstetrical care needs to be in the policies. And if a woman is not going to have children and plans not to have children, why should she have to pay for obstetrical care? So that's one reason why some people might not like it, the Affordable Health Care Act. The other was that they had to actually buy the insurance, and if they didn't, they would get penalized. Gail Lewinsky said, what a way of we should have looked at this is much like we looked at Medicare Part D. If you don't buy Medicare Part D at the very beginning, you will be penalized when you do start buying Medicare Part D. You will have to pay more for it. So we already have a precedent for getting around this individual mandate, and I think it's something we will be able to get around.
So, yeah, and so I think that's the most unpopular part of this whole thing, requiring everybody to have insurance.
It's interesting that Kaiser Family Foundation, which does lots of research on health policy, did a poll a couple years ago, and they looked at 15 different elements of the ACA, and 14 of the 15 were reported by the respondents as favorable. Only one was where did not get majority support, and that was the individual mandate. 14 of the 15, the other important parts of the law were all looked upon as important and favorable.
And very quickly, why don't you just touch on what else does Obamacare or the ACA do? What other things besides this required?
Well, there's quite a long list. It requires insurance companies. You mentioned some of the things that are required of insurance companies. Probably the most fundamental thing, and maybe even more important than the individual mandate in my view, is the ACA supports the development of new payment structures and new healthcare delivery models that reward providers, be they hospitals or physician groups, who provide efficient and effective care rather than just providing more and more care, which is what is rewarded in the standard fee-for-service system.
Right.
It also, there's also things like malpractice reform, support for investigation in other models, and a number of other, lesser things. But one of the problems that in this country is the way we pay for care, which has rewarded people that did more, but without regard for whether they did the right thing or whether their patients actually did better.
Right.
And so now hospitals are being penalized if they have unnecessary complications. Readmissions, they're being penalized if people are being readmitted when there really wasn't a good justification for that. And that is working. The readmissions are going down, hospital complications are going down, and when you shine a spotlight on things, and especially if there's some dollars attached to it, things change. And that's,
so it's a good thing of the ACA.
I think long term that may be even more important than the insurance thing, because the bottom line is, the reason we have all these insurance problems is healthcare just costs too much.
Yeah.
And we've got to learn how to deliver it more effectively and more efficiently. And if we do that, hopefully insurance will be more affordable.
We could spend a show or two on waste, and none of us would have any problem. I would like to contrast what the ACA is in that it supports and allows private enterprise, the insurance industry, to stay alive. It just reformed it so that it actually did what it was supposed to do, instead of trying to survive by dumping the sick people and only covering well. So it is really private enterprise, a conservative approach really to healthcare
absolutely.
financing.
The exchanges are a perfect example of an open free market. And our experience here in South Dakota is that works, because the first round, there was one insurance company that overpriced their product and they got no enrollees.
Right.
This year they came back with dramatically lower prices and they got a large number of enrollees. So, and people switched, people did shop, so that it really is an open free market, and it works like a market. Once you give people the information they need and policies are comparable and they're in a structure where they can really set them side by side, then people can make decisions.
That's interesting. Let's have that question from Lynn Sanderson about comparing this ACA versus Teddy Kennedy's idea of years ago.
the way I think is it didn't go quite far enough. And I'm really an advocate for a single payer system where you just for everyone. So, and I think that Congress has that. They have like a Cadillac of healthcare. And so I would like to see that offered to the citizens. I personally know of one person who has had great success so far signing up for Obamacare and getting it really discounted and everything. When I tried, when I got down to the bottom, my cost as a single person was going to be about the same as I was paying already. But I think my new plan would have included dental care, which I don't have. So I just kind of was lazy and abandoned it. But I know of one person that has a great rate with it.
Single payer system, Don.
Rick.
Yeah.
I have thought about this a great deal. I guess Tom has actually worked in a single payer since he was in England, but I think most of us worked in a single payer. I was in the military for 3 years, but the biggest system that we have that's a single payer in the United States is the VA system. We have a great deal of experience in that. So if we really wanted to look at a system, we could look at our own system and see how it's working. But I think one of the other things that we have talked about a little bit, though, I think is really also very important about what the ACA is doing, is that it is looking at different methods of care. And we know from the Commonwealth Foundation looking at other industrialized countries that the country that has more primary care has a better cost structure and does not spend as much money, but the outcomes are as good or better. And the ACA does support the patient-centered medical home and supports more primary care physicians being involved in the health system. And I think that's one of the very important things of the ACA.
Well, and that brings, of course, Don, you're a primary care doctor and a primary care internist like I am. You're a primary care family physician. Right. So you've got three people who believe that you're right on that one. But unfortunately, the trend in the United States is to specialties. Tom, would you speak to that?
It is, and for a whole variety of reasons, whether it be income, lifestyle, a whole variety of things, young physicians have trended toward the more narrow specialties. There is some evidence that that is beginning to change a little bit. The number of young medical school graduates going into family medicine residencies has steadily increased in the last years. Not enough, but the trend is definitely upward over the last year. So there's some evidence that it's shifting, but we face a huge problem because we have a serious deficit of primary care physicians right now. Many of us are aging, and with these new payment structures, there's going to be a demand for even more. So all the indications are we're headed for a very serious primary care shortage.
Right. We have a graphic that talks about what's happened in the United States compared to other countries. It says that there are 34 developed countries in this group, that in U.S., our life expectancy is 25th of the 34. We're 32nd in infant mortality, and yet we're way much higher in expenditure. Do we have a reason can we explain why we cost so much and yet the quality, this is maybe a measurement of quality, the quality isn't as good as it should be? I'm going to ask both of you to answer that one. Don, we'll start with you.
Thanks. It's a big problem. Part of it is the way that we deliver care. It's very common that we go to organ-specific doctors for a problem. If we think we have a cough, we want to see the pulmonologist. And we pretty well know that pulmonology or subspecialties tend to use a little bit more technology, and their cost of care is a little bit higher than a primary care physician. The outcome is pretty much the same. There's some, obviously, some of the specialists might think that's not the case, and they do have some anecdotes where that's not the case. But it does cost more to have a specialty care. For instance, if we look at some of the technology that we might use, we are more apt in the United States to have an MRI or a CAT scan to evaluate a problem than any place in the United States. We have more MRIs and CAT scans per population than any other country. We utilize them more often, and the fact that we do utilize them more increases our costs.
There is one exception to that. Japan has more MRI machines than we do, but my understanding is an MRI scan in Japan costs about $200 or $300.
Right, there you go. So there's a different part of that.
Yeah.
And of course, if this is, MRIs and CAT scans are powerful tools. Somebody comes in with abdominal pain. Instead of opening them up to see if there's an appendix, you can see, there's a tumor, or it's the gallbladder, or it is the appendix. But really, the way we used to do it, and the three of us have had that experience of a lifetime of knowing when you called the surgeon and we didn't have to do the CAT scan, and you knew that you would go in there and take out that appendix or that gallbladder. You could tell it by your clinical suspicion, and you didn't need the CAT scan. I think we would all agree that we probably do lean on that too much, but we expect it. People expect it, don't they?
And there certainly are evidence that in properly used, that technology benefits patients and probably saves money if it's used properly. But that's the real question.
Right.
What Don started to say was so important, that when the individual narrow focus specialists, especially as our population ages and people have multiple different diseases, we hear, I'm sure you hear it, I hear it, that they're in the hospital in the big centers and they say, well, I saw 4 or 5 different doctors and I didn't know what was going on, because there really wasn't anybody that was coordinating the care and communicating all that to the patient and making sure that things were not being missed or duplicated, and especially when the patient gets ready to go home, make sure that all of these recommendations are coordinated and don't conflict with each other, and they're things that the patient can really do.
This whole hospitalist system that we're moving toward, some would say, loses that particular coordination care. Whereas when you see a patient in Wessington Springs, you see them in the hospital, you take care of them in the hospital.
I will toot our horn a little bit. One of the big concerns about costs over the years has been this readmission rate. That there was a study a few years ago that showed that 20% of Medicare patients that were hospitalized for a condition were readmitted for the same condition within 30 days. And it cost Medicare something like $15 billion a year, or some outrageous number. In Wessington Springs, our readmission rate is 5%. And we take care of some difficult patients, but the difference is that it's the same people that take care of them in the hospital, see them in the outpatient. They don't come in for the appointments. We know about it.
It's huge.
It makes a big, and it's just very simple, basic things that make a difference.
So we were saying all these good things about ACA. I mean, most of us would agree that we're hopeful that it will move on and fix itself and advance on these things. But there's a lot of resistance. We have a question from the audio, from our reporter.
What are the opponents of the ACA offering as alternatives?
That's the question. Don, what's your comments about the people who are trying to bring down ACA, and what kind of alternatives do they have?
I've been waiting with bated breath for that particular issue. I'd like to know too. And I don't think that we have seen a substantial production from the people who don't like the ACA. I know that they are trying to develop an issue and a plan right now, but I have not seen it.
There have been some proposals floated. The ones I've seen, interestingly enough, use very similar structures as the ACA. They just simply don't cover as many people. They don't have the requirements. And so in terms of the number of people that will be covered, it'd be significantly lower than the ACA. And they do away with the individual mandate, but still put the same onus on insurance companies of requiring them to take all comers, which, as we spoke about earlier, is just not viable from an insurance point of view.
If they did that, your prediction is that the insurance industry would self-destruct in about 5 years?
Who knows?
And my guess would be at that point, everyone would be so frustrated that we'd end up with this single-payer system.
We would end up with a single-payer system. Yes.
You know, I don't want to be political, except that it was the Conservative Heritage Foundation's idea to do
the individual mandate.
Yeah,
it is.
And it was. I know that it was Bush's alternative to the Clinton plan, which was an employer-mandated plan.
Yep.
So I'm frustrated because I think the conservative idea of allowing private enterprise to stay alive is a better option than ending up with a single payer system. Personally,
one of the structures that the ACA supports is a thing called accountable care organizations, and it really does support and encourage individual creativity and initiative. What it says is Medicare would make a contract with a group of physicians, probably associated with a hospital, to take care of a group of Medicare recipients. And if they could meet certain outcome benchmarks and do so for less cost than Medicare would otherwise Medicare have to spend, Medicare would share those savings with that group of providers. And that really encourages individual creativity, and there would not be this top-down dictation of all the regulations that drive us all nuts. But this would say, if you can do it cheaper and more effectively, we'll support you. We're not going to tell you how to do it. And I think that's a huge step forward.
That would be a wonderful thing. So what has happened, though, with the ACA? Now, I mean, there's been a lot said that it's very, very expensive. Some people's health care insurance cost has gone up. This is a government plan. I would say it's not. It's reforming health insurance industry that's costing us more and more. What's your take on that, Don? Do you think that it's failing, or is it succeeding?
Well, I can maybe talk to it a little bit about what is the ACA's impact upon me. One of the things that has been the biggest impact on my practice from a financial point of view was the High-Tech Act, which was part of the Stimulus Act, which passed in 2009, a year before the Affordable Health Care Act was passed. And that was a way for physicians, if they proved that they were using their computers in a certain way that made use of the computer to, other than just keeping notes, but actually coordinate care and advance the care of patients, that the government would pay us money over a period of time. It was over a 5-year period of time, because it was President Obama's feeling that all healthcare should be delivered by providers who were using computers. And this particular act allowed the payment to physicians, if they followed certain regulations, to be able to get that money. I've been able to do that, and it's been a big boon to my practice, because my computer system cost me about $50,000 per physician. There are 9 of us, so it was nearly $350,000 for us to buy the system. And the government over the last 5 years has nearly paid us back. But it brought into the idea of care that we needed to have meaningful care. So it has been moving now, and the Affordable Health Care Act wants us to move to that, is to pay us by our value, not our numbers of patients that we see. And the quality of care is something that I always used to just take it was just something I always do. I gave good quality care, but I never really looked at the measures to see if I really did. And what the Affordable Health Care Act and this act of high-tech has done has made me actually look at my practice and prove to myself and to the government, the payers, that I really do give good, high-quality care. There are some problems about trying to look at, how do you decide that? But I think indeed we do that. So I've made more money under the Affordable Health Care Act. Plus, I'm seeing patients that I usually didn't see. Like when they come for the first Medicare exam, I give them all these preventive things. I have seen children of patients who are up to age 26 who have insurance now where they didn't used to have insurance. I've seen patients that I haven't seen before because they've signed up on the exchanges. So the impact on me as a primary care physician has been a positive one.
Right. Talk to me about what's happened with Medicare and the money. Are we losing money in Medicare because of the ACA?
Well, that was a charge that was made. A number of politicians claimed that $700 billion was stolen from Medicare to fund the ACA. In fact, that simply never was true. What happened, it's true that the projections of Medicare costs went down, but at the same time, Medicare benefits went up. So the care that was provided to beneficiaries actually increased. But what was different was because of a variety of other impacts of the ACA, the cost of Medicare to the government has actually declined. Not declined, it just hasn't risen as fast as was projected. And as a result, Medicare as a program is more stable now than it was when the ACA was first passed. When the ACA was first passed, the Medicare Trust Fund, the financing of Medicare is very complicated, but the benchmark is the Part A Trust Fund, which is where your Medicare taxes go. And at the time the ACA was passed, that was projected to become insolvent in 2017, which was only, 8 years beyond the passage. If that had held, we'd only be 2 years away from Medicare insolvency. Because of the decrease in cost to Medicare of the variety of the impacts of the ACA, the projected solvency of the trust fund now goes out to 2030. So it's been expanded by 13 years by the impact of the ACA. Now, that's not nearly enough.
We've got to do better.
We got to do better because even 2030 is going to come pretty fast.
Yeah.
And I mean, it needs to be solvent. We need to figure out a way that we can project solvency 50 years down the road.
All right.
But it's moving in the right direction, so the ACA has actually been a benefit to Medicare.
All right, we've got 2 minutes left, the two of you guys. We've got one question I'd like to make sure we hit. Don Crow, please.
If the Affordable Care Act provisions for state insurance programs done by the federal government is stricken down, what happens to those people who signed up?
So what would happen if the ACA was repealed? What would be the end result? Don, how would you put it?
Yeah, I don't know the answer to that, but I do know that some of the predictions has been that if subsidies cannot be given to people who have signed up through federal exchanges, they feel that the whole act is down.
Don, I can't, something's happened to your communication. I can't hear you, but we'll get back. Yes?
The first thing is a lot of people are going to lose insurance. That'd be the first impact. And the case that's before the Supreme Court right now, if the Supreme Court supports the challengers, a very large number of people that now have insurance will lose insurance.
The exchanges go away that are government, that are U.S. government.
Those states that have chosen to administer the program through a federal exchange, the subsidies that are provided there will go away, and apparently they'll go away very quickly. That's very scary. That's very worrisome.
Don, 10 seconds. Any final word?
I really enjoyed doing this. I hope that the listeners have gained something. I do think that it's very important for us to do, as Tom had suggested, to take care of ourselves and be healthy.
Thank you so much. Thank you both. We'll be back right after this.
When you quit smoking, you get extra cash in your pocket right away.
Yeah.
1 month and you've got $150 extra you didn't have before. Quit 6 months and you have an extra $1,000.
Oh.
$2 grand in a year, $4 grand over 2 years, and a whopping $10,000 in 5 years. Nice chunk of change. So take a deep breath. You can do this. We can help.
Who first came up with Obamacare? The Patient Protection and Affordable Care Act, or the ACA, sometimes referred to as Obamacare, was developed to reform the health insurance industry in order to, number one, expand health insurance and Medicaid coverage so that people who were being denied coverage now would be able to get it. And number two, reduce the cost of health care both to the individual and to our society in general. Prior to the ACA, leaders and legislators had been trying for years either to, one, regulate health insurance so that it would actually do what it was supposed to do and protect people from gargantuan health care costs, or two, dump the insurance industry and replace it with a government-provided single-payer system. Despite hard work and great leadership to resolve the problem of coverage and cost, diverse interests seemed to block it at every turn. Most notable was the conservative Republican Heritage Foundation's proposal of the individual mandate, requiring everyone to have insurance and every insurance company to cover everyone, thus keeping and reforming the U.S. health insurance industry. Following this, an individual mandate program, sometimes called Obamacare, came into existence in the state of Massachusetts. These efforts were in contrast to the earlier efforts of liberal Democrat Ted Kennedy to have a single-payer, government-controlled, British-like system, or the centrist Democrat Clinton idea of employer-mandated health insurance. Reform legislation finally passed under the Obama administration, surprisingly leaving intact the insurance industry and following the individual mandate Republican idea. Well, for whatever reason, it met great Republican resistance. To make it happen, the president utilized some rather strong-armed methods and irritated the Republican opponents, even though the plan was originally their idea. Now, due to the politics of it all, we have in Washington something like a dysfunctional family, so polarized that each side cannot seem to be willing to listen or compromise on any issue. The ACA has its flaws and needs some work, but it is not just my opinion on this one. If we cannot find a way to reform the health insurance industry so as to provide coverage for all, rich or poor, and control costs for the individual and our society, then we could end up with a single-payer system, and that would have a huge challenge of its own. As this president retires and we vote for new leaders in Washington, may we look for people who are willing to concentrate on what would be best for the people and not so influenced by the politics of it all. This brings us to the end of our show this evening. I sincerely thank tonight's guests, Dr. Tom Dean and Dr. Don Hatton, for their insightful additions to our investigation of the ACA. As we all think about health care in America, maybe advice from President Dwight Eisenhower will help. Neither a wise man nor a brave man lies down on the tracks of history to wait for the train of the future to run over him. And until next time, stay healthy out there, people.
Funding for On Call with the Prairie Doc is provided in part by
Avera is a proud sponsor of On Call on South Dakota Public Broadcasting.
Larson Manufacturing is proud to support On Call Television as it continues to open doors for important medical information.
And by the South Dakota Foundation for Medical Care, the Medicare Quality Improvement Organization for South Dakota.
Additional funding is provided by
Aberdeen Asthma and Allergy,
Brookings Health System,
Dakota Allergy and Asthma,
Dakota Care,
Dakota Dermatology,
the Orthopedic Institute,
Physicians Care Sanford Clinic Community Service Committee, and Swiftel Communications.
Closed captioning for On Call with the Prairie Doc is provided by the generous support of
Avera,
Brookings Health System,
and Fishback Financial Corporation.
Things. We're streaming live, we do social media, things like that, because at some point, as that population ages, they're going to become our audience.
Yep.
So, I mean, it's important that we...
It's important to do it,
those.
yeah. No, you do a great job, and somehow we need to acknowledge that.
And don't forget to thank Dr. Hatton.
Thank you.